Welcome to the Health Focus Podcast, brought to you by Memorial Healthcare, where we discuss current trends and topics in healthcare that are important to our local Shiawassee community. We are coming to you, as always, from the Now Building and our podcast studio. I will be your host, Dr. Gregory Flamone, a general surgeon here at Memorial. With me here today is Dr. Brett Walker, a board-certified and fellowship-trained orthopedic spinal surgeon. Dr. Walker, thank you very much for joining us. Why don't you start out with just telling us a little bit about yourself and what brought you to Memorial?
Sure. Well, thanks for having me. So my name is Brett Walker. I'm originally from Metro Detroit, Grosse Pointe, and made my way through training at Michigan State, both through undergraduate and then medical school. Did my orthopedic surgery residency at McLaren Oakland in Pontiac, Michigan, and then I went out and did my spinal fellowship at the University of Washington in Seattle. Worked back here in Michigan for a few years to be closer to family and friends, and then found my way to Memorial by way of a colleague who works here as well. Found a need in the community. There wasn't previously any spinal surgeons here in the area, and so thought there would be a good opportunity to help bring high-quality spinal care to the patients who are here without having to have them go outside our own community to receive treatment.
And as a fellow surgeon, it's been amazing. It's a new service line that we desperately needed here, so we enjoy having you here, and I know our patients do too.
I appreciate that. Thanks.
So in layman's terms, for the people listening to this podcast, what is a spinal surgeon?
So there's a couple different ways to become what we call a spinal surgeon today. And so either traditional routes would be orthopedic surgery or neurosurgery. And so after medical school, you would do training in an orthopedic surgical residency or a neurosurgical residency. Once that's over, you have the opportunity to do additional training beyond the general practice of either one of those specialties. And so one of the options is spine surgery. And so it's called a fellowship at that point. You go out and do an additional year of training in just that aspect of your specialty. And so I mentioned at University of Washington in Seattle, we did just spinal surgery for the entire year, learned about the intricacies, the more difficult cases, and you can do that either through an orthopedic surgery residency or the neurosurgical side. And so in today's climate, really there is no difference if a patient was to see a neurosurgeon or an orthopedic surgeon who do spine surgery. We all do the same types of procedures. So a little bit different background to get to the same place, but once you're there, it's effectively the same specialty.
So the fellowship are all the same. You're doing the same procedures, treating the same diagnosis and things like that.
Right. So most of the fellowships in today's training programs are done at big academic institutions where both the faculty are orthopedic surgeons and neurosurgeons, relatively interchangeable between the two. And so, yes, all the same types of procedures, all the same training and education goes into either way.
So what are the common diagnoses that you see? Is there something that outweighs more? Are there different depending on location, cervical, thoracic, lumbar?
So trauma factors into spinal surgery all the time. So broken bones, fractures, things like that. Certainly that's one aspect of it. So if somebody is unfortunate enough to have a spinal fracture, they'll typically will see a spinal surgeon for either non-surgical or potentially surgical intervention for that fracture. Far and away, the most common thing that we would see would be spinal stenosis. And what spinal stenosis is narrowing of where the nerves are located in the spine, whether it's the cervical spine, which is the neck, the thoracic spine, which is sort of the mid-back around the rib cage, or the lumbar spine, which is the low back. Nerves can be compressed in any one of those areas, and that term is called spinal stenosis. It's compressed for various reasons, but the most common is arthritis of the spine. And so arthritis of the spine leads to thickening of the ligaments that are normally there, the bones that's normally there, and those create narrowing of where the nerves are and lead to symptoms. Another very common cause is disc herniation. So people may describe disc herniations, and that can lead to spinal stenosis or the narrowing as well.
So what are common symptoms of spinal stenosis for our community to know, hey, this might be what's going on?
So one common misconception is that because it's a problem with the back, you're going to feel it in the back or the neck. So what really happens is that the nerves, yes, are located in the neck or in the back, but the symptoms are really felt in the arms or in the legs. So typically, if you have spinal stenosis of the neck, you may experience numbness or tingling in the arms, pain, which people may refer to like a sciatica pain. In medical language, we call it radiculopathy, but it's basically shooting pain that goes into the arms. Weakness is another symptom. When things go on long enough, the nerve gets compressed long enough, it can cause a weakness. So usually if it's a cervical issue, it'll be felt in the arms. And then if it's a thoracic or more commonly a lumbar issue, you'll feel it in the legs. So numbness, tingling, shooting pains, and weakness. They don't go the opposite way, though. So issues in the neck with the spinal cord can affect the arms or the legs, but I tell patients, think of the nerves kind of like a waterfall. In the lumbar spine, you're not going to get symptoms in the arms. So it's usually felt in the extremities more so than just the back or the neck.
So a patient has these symptoms, they see their primary care. Is there normally a workup that the primary care starts, or do they come to you? And what do you see, is it that patient walks in your door?
So we see a mix. Sometimes patients already come to us having tried many different non-surgical options. They've already had advanced imaging, and sometimes we see people for the very first time who haven't had any treatment or any testing done. So typically what will happen in the office when we see a patient is we'll obtain an x-ray to look at the bones. That shows us the bones, shows us the disc spaces, shows us some things that we're looking for as potential culprits for the pain that's being experienced. Usually we'll go on to get an MRI if there's symptoms of the numbness, tingling, or pain, because an x-ray doesn't show us the soft tissues and it doesn't show us the nerves. And so we need those tests to sort of look deeper at the structures and localize things so that treatment can be kind of tailored to exactly what their problem is. After the testing's done and we've located the potential cause of the problem, we generally would start with non-surgical treatments prior to considering any surgery.
What type of non-surgical treatments are there for spinal stenosis?
So we generally start with non-surgical modalities like physical therapy to begin with. And physical therapy focuses on core strengthening and range of motion as well as stretching of the nerve roots to mobilize the nerves that may be being compressed in the spine. Another option that we use is chiropractic care. And so much like physical therapy, it's a manual therapy in order to do some decompressive work and realign certain aspects of the spine that can help to improve the symptoms. When those don't work, we can do medications. There's certain medications, not necessarily pain medications, but medications that work on the nerves themselves, and those can be very important to help with the neurological symptoms in the extremities. Another option that we use frequently is injections with our pain management providers. And so pain management providers are either physical medicine and rehabilitation doctors or anesthesiologists who've done additional training to provide these types of injections. And common injections patients might get are epidural steroids or something called medial branch blocks. And these focus on the structures around the spine that surround the nerves and are generally thought to contribute to the symptoms. And all of these things can be used together or separately, kind of tailored to each individual patient to hopefully avoid the potential of surgery in the future if the symptom itself can be controlled.
How successful is that? Like, I mean, ballpark percentage-wise, are you able to get a good amount of relief on most of your patients, or kind of what do you see in your practice here?
I'd say the majority of patients that I see don't end up having surgery. So that is promising for non-surgical things. It's always a spectrum, though, because smaller things can be treated with less invasive options and larger problems typically need more invasive things. So everybody's a little bit different, and each individual case is handled individually. But we always attempt to start, except for a very few small or more emergent conditions, start with these modalities. And again, the majority of the patients in my practice do not ever end up going on to spinal surgery.
Right. A lot of people, I mean, as a fellow surgeon, they think all we want to do is cut.
Right.
They don't realize what really goes into it before we actually take them to the operating room. What are the common surgical treatments for the spinal stenosis? What cases are you doing on a regular basis?
So the majority of these types of treatments now surgically have become less and less invasive as time has gone on. So historically, they've involved huge incisions, long hospitalizations, and a long, prolonged recovery. But over the last several decades, and certainly in the last 5 to 10 years, more minimally invasive options have become available, and the majority of what I actually do is done as an outpatient nowadays. And so common procedures patients may hear about, for example, if you have a disc herniation, we would do something called a microdiscectomy, and that's microsurgery. We use a very, very big microscope to look at the small structures through a very small, sometimes 1 to 2 centimeter incision over the spine, and that's all we need to remove the piece of disc which is pushing on the nerves. Another common procedure is a laminectomy, and this is done more for thickening of the ligament and the bone structures that are big. But again, two or so centimeter incision, 45-minute surgery, patient goes home the same day. In more severe cases, we do spinal fusions, and spinal fusion tends to be kind of a bad word out there. People are generally more cautious about, and rightfully so. But there are certain situations where screws and rods and fusions are necessary in order to protect the structures and fully decompress those structures in order to provide the relief that we're looking for post-op. And even in those situations, generally it's an overnight hospitalization and not prolonged recovery of weeks. People are up moving the same day as surgeries. They're living pretty normal lives through the recovery, albeit with some surgical site pain, which we control with medications.
So it's about functionality. It's getting back symptom relief and keeping them on their feet, keeping them going.
Correct.
So what can a patient expect? That spinal surgery experience, it's outpatient, but what is that recovery like? And how long will they be off their feet? out of work, or what does all that all depend on?
So it really depends on the patient's particular situation. So we kind of have a spectrum of these surgeries, and the recovery time depends on which surgery you have. So it can range from 6 weeks of restrictions to 12 weeks of restrictions in general. And the restrictions depend on the type of surgery that's done. And so usually for cases where we're not doing fusions, we do about 6 weeks of restrictions. And those restrictions don't mean you're not living a fairly normal life during that time. It just means that we have to protect the surgical site. And in general, that means lifting restrictions, so not lifting over a certain amount of weight, or deep bending and twisting restrictions. But surgical pain generally diminishes within about a week to 3 weeks after the surgery. So after that time frame, the restrictions are really there in place to help the deeper structures heal and not about patient discomfort. I would expect every patient we're doing these outpatient elective surgeries on to be up and walking the very same day. So sometimes that affects work and things like that. For people who have desk jobs or don't require lifting and twisting or are more flexible in their work, they can go back to work within a week to 2 weeks. For people who do more manual labor or work where they're required to lift heavy weights or bend frequently, it may be up to the 12 weeks. So it really depends on the patient's specific situation.
How do comorbidities play into your surgical decision? Diabetes, obesity, smoking. We have a lot of that in Shiawassee County. Does that preclude you from doing certain things, or, kind of how does that play into it?
I try to be really evidence-based with the way I do things, and so there's a lot of research, particularly in spinal surgery, about some of the things you mentioned. And so just because you're diabetic doesn't mean you can't have surgery, certainly. So we do hemoglobin A1C tests to ensure that we're maximizing outcomes in that regard. And so usually the literature will recommend between or less than a 7 to a 7.5 of that A1C number. And the reason for that is to reduce the risks of surgical site complications. And so anytime you cut the skin, there's a risk of an infection. We know when those A1Cs go higher than that risk substantially increases. And so if it's a modifiable thing that we can help to address prior to surgery, there's certainly benefit in that. Smoking is another one. Again, fusions, it's a big deal because patients don't heal nearly as well with the fusion because it's similar to healing a bone. And we know from fractures that patients don't heal bones nearly as well when they smoke. And so again, that's a modifiable thing. And insurance companies are really paying attention to smoking as well. So for spinal fusions, it is difficult for smokers, and we need to work on some of those things, again, just to maximize that. Everything we do with the literature is designed to decrease the rate of problems. Really, we want to have the best results possible, and they are excellent results. But if you can modify certain things to improve those results, you certainly don't want to have somebody have a complication if it's avoidable.
Great. So what is the future of our spine program here? You've been here a few years now. I've seen your volume increase. What's down the road for the spine program?
So we're working on building relationships with institutions around the area to start to bring patients also in from outside communities. I recently have met with some pain management providers within our own community and also interested providers outside our community to help grow our volume here. First and foremost, the priority is to ensure that every patient who can be cared for from our community at our institution is cared for. And so we're looking to expand our technology. We're looking to expand the ability to do different and more invasive procedures. And we're also looking to build this program up to where people are coming from outside community to ours.
Well, I appreciate your time. Is there anything else about the spine program you'd like to talk about before we sign off?
I'm just really excited to be here. I've been here now, it'll be about 1.5 years, almost 2 years now, and things have been great. The community's wonderful. It's been a really big pleasure to serve the community and help patients, and I think the results that we're seeing are promising and excellent for the community, and I'm just really happy to be part of it. So thank you very much for having me.
Well, we do thank you from Memorial and the operating room staff. You've been a pleasure to have here, and we hope this continues to grow. That brings us to the end of today's episode. Again, thank you to Dr. Walker for joining us. And as always, thank you to our listeners for listening to Health Focused, our Memorial Healthcare podcast. If you've enjoyed your show, please rate and review us wherever you listen to your podcasts. Again, this is Dr. Flamone, the voice of Memorial. We'll see you soon.